I realized when I sort of look back at my videos on endometriosis, we didn't really spend a lot of time covering diagnosis of endometriosis. So I hope this video makes up for that. I think the first thing to say about diagnosis of endometriosis is that if there is a clinical suspicion of endometriosis, there should be treatment. It's not like any other condition because it's so debilitating and it causes such disruption to normal life and functioning. If a clinician suspects endometriosis, the guidelines say that we must instigate treatment, whether it's instigating some pain relief, hormonal therapy, referring to a gynecologist who has endometriosis experience. We really shouldn't wait for a definitive diagnostic test that says, yes, this person has endometriosis. I mean, one of the reasons for this is that there is no definitive diagnostic test. I think clinical suspicion based on history and examination and listening to symptoms, including a pain history, is one of the most crucial things about diagnosing somebody with endometriosis. And often in my practice, listening to histories about pain and infertility is enough for me to say, okay, let's instigate some treatment for endometriosis. What is available out there? There's imaging. Ultrasound is often used to try and diagnose endometriosis, and the reality, however, ultrasound is not that good at diagnosing endometriosis. There are certain indirect markers that tell us whether there is an endometriosis present. So these markers include the presence of adenomyosis, the presence of endometriomas on the ovaries, the presence of secondary effects that we see from endometriosis, so that is scarring to the pelvis that we can sometimes pick up on a good quality ultrasound. MRI is actually very good for diagnosing the deeper forms of endometriosis, especially when endometriosis involves invasion of other bits of tissue like the bladder or the bowel. But of course, access to MRIs is very contentious and very variable. The gold standard for endometriosis diagnosis is still laparoscopy, which is a keyhole procedure to visually see endometriosis. Even that is not 100% foolproof. For people to see endometriosis on a laparoscopy, on a keyhole procedure, the person operating laparoscope, the surgeon who's doing the procedure, must have a high index of suspicion. If that person just has a cursory glance at things, there can be very subtle disease that is missed. And for those of us who do a lot of endometriosis work, we're super paranoid about having a really good look everywhere in the pelvis and in the other organs to make sure that as far as we can see on that detailed look afforded by the laparoscopy, that there is no endometriosis that we can see. And keep in mind, that still doesn't mean that there's no microscopic disease that we can't see. Laparoscopy, even though it's a common procedure, is still a surgical procedure that comes with risks. So I suppose what I'm trying to say is that you don't need a laparoscopy to be diagnosed with endometriosis. Clinical suspicion is enough. Finally, there is a type of ultrasound called a deep infiltrating endometriosis scan that looks at deep disease. This is disease that is growing through the layer of tissue that covers the internal organs, through that layer of tissue and into the organs underneath, the bowel, the bladder, or the base of the uterus. This scan needs to be done by a trained person who has spent time and experience doing this type of scanning. It's not available at your sort of corner ultrasound place. It only is done by experienced gynecologists, and it needs a specialist referral, but that can sometimes give us an idea of how severe the endometriosis is, whether there is deep endometriosis, and it helps us with surgical planning as well. So really, the takeaway message is there's no non-invasive gold standard tests available to diagnose endometriosis. There is no blood test, urine test, or any other biological markers that we have found so far that can diagnose endometriosis in a relatively non-invasive way. Laparoscopy is not fail-safe for the diagnosis of endometriosis. Just because we haven't objectively diagnosed the disease doesn't mean the person doesn't have it. Therefore, we would all or should treat based on clinical suspicion, based on our conversations with the patient.